I'd just like to start by paying my respects also to the traditional owners of this land and to the elders past and present. And thank you also to Cancer Australia for inviting me here, and thank you to all of you for turning up. I guess, this is a bit of my journey. It's working. Awesome. Okay. Well, really, the Cancer Council's journey of at least 10 years now of similar to sorry, I can never say that now, Shouty. About 10 years ago, the CEO of the Cancer Council, I was working as the biostatistician at the Cancer Registry. He comes knocking on my door, the CEO of the Cancer Council, says, Raj, in a couple of weeks, Senator Aidan Ridgway is coming here for NAIDOC week. It'd be nice to have a bit of stats about Aboriginal people and cancer, a few numbers you can knock up. I said, that should be easy enough, Andrew. And of course, I went to the Cancer Registry, and really the quality of the data there was really poor and for Aboriginal people, and we found, it made me think why, why is it that we don't have that information, and what can we do to improve it? And so that little question that Andrew asked me 10 years ago, I'm still working on. And hopefully we're just getting now nearer to the end of that journey. There were things we did know at the time. We did know that almost 30% of Aboriginal people lived in New South Wales. Come on. Here we go. The cancer was the second most common cause of death for Aboriginal people at that time. And that when we did a little bit more digging and a little bit more quality assurance, we found that Aboriginal people were 60% more likely to die from their cancer than non-Aboriginal people. And for some cancers, it was almost 3 times higher. So this is 10 years ago. But yet, even though we knew that outcome, that there was this disparity, we didn't know why. We didn't know anything about the cancer journey. What were the things that led up to that disparity? So it's one thing to identify and quantify the disparities there, but we didn't know what was causing it, whether it's usually in these sort of things when you identify a disparity in between population groups, it's either later diagnosis or lack of treatment or something along that pathway that gets lost or delayed. So we really wanted to try and work that out. So we put in we came up with this model, please. Yes, there we go. Of the cancer journey, and we formulated what was known as the APOCC project, or the Aboriginal Patterns of Cancer Care project. And we had the sort of patterns of care part here, which is really looking at from the diagnosis state onwards, what care did people get once they were diagnosed with their cancer, and how did the cancer care for Aboriginal people compare to that of non-Aboriginal people? We then did also a similar study, but this one was an interview-based study where we looked backwards from diagnosis, saying what were the barriers that maybe were there for people getting diagnosed at an early stage. And finally we did, similar to that's already been talked about, a qualitative study which looked across the whole cancer journey, trying to understand what people's experiences were. And we interviewed not only cancer survivors, but people who worked with Aboriginal people with cancer, as well as carers for Aboriginal people with cancer. So it's quite a comprehensive, and we thought all-encompassing sort of study to put up. And luckily for us, the NHMRC thought so as well, and funded it as well on the first go, which is really good. So what are quantitative research questions? These are the ones that I'm most involved with, and these are slightly different to the ones that we've been talking about this morning. The things are about simple questions that we didn't know about and we really wanted to find out about. And things like, how many Aboriginal people had cancer treatment? It sounds like a very obvious thing, but we didn't know, and we didn't know how to get it until we started doing this study. Did Aboriginal people have the same types of cancer treatment as non-Aboriginal people? That's an interesting question, because often there's a lot of variables in there, whether it's doctor choice or patient choice, about the sort of cancer treatment that you'll get. And obviously too, the other things too is where you live can sometimes limit the types of treatment that are available to you. If you live too far away from radiation therapy, then maybe chemo or surgery may be the only options. And did Aboriginal people have the same survival as non-Aboriginal people? That's a really important question that we're going to know. And one of the first paper that we've published about this is there we go. Just published this year, hot off the press. This is a paper we published earlier this year, looking at the survival of Aboriginal women with breast cancer and comparing them with non-Aboriginal women with breast cancer. Now, this is a paper that we published about March this year, and I don't know if most of you know what it's like to be a researcher, but we sit in a basement, literally a basement, and we write our papers and we publish them. And in the old days, you'd publish them and maybe you'd wait 3 years for someone to cite the paper in a different publication, and you go, oh, well, that was useful to write that paper. Nowadays, though, with these open access journals, and we're really trying to target these journals, anyone can download this article at any time and use it for their information. So I encourage you to do that. And this particular series of journals, the BMC series, actually gives a lot of feedback on what's happening to our article, and it's really great to see that over almost 1,500 people have already downloaded this article. So there's interest in it, and it's something that we hope will make a big impact into cancer services. And not only that, it's one of the top 1% most tweeted articles of all time. So there's a lot of interest out there, and it gives us confidence too that that we're doing the right thing and that people are interested, and we're publishing results that people can use. So what actually did we find? So we found that compared to non-Aboriginal women with breast cancer, Aboriginal women were diagnosed younger and with a more advanced stage of disease. They had surgery, though, at a similar rate and a similar time after diagnosis. That's a good news story, really, that often you hear, about long delays and things like that, but actually most women were getting the treatment within about 2 weeks of their diagnosis. So that's a good story to know. But they were also more likely to have chronic conditions when they were diagnosed, such as diabetes or cardiovascular disease. So that sometimes has an impact on the treatment that people can receive. When we looked at the mortality figures, you can see here that at around 18 months, in fact, we found that Aboriginal women and non-Aboriginal women had about the same survival. This is something that's never been shown before. Usually with these sort of graphs, and if you had the same graph for lung cancer, you'd find from day one there's a splitting of the survival from day one. Whereas this probably is an indication of the fact that, like I said, Aboriginal women are getting their treatment, their surgical treatment at least, in a timely fashion. But this splitting afterwards, where in the end, after 5 years, you find that Aboriginal women are 50% more likely to die from their breast cancer. So that's indicative often of less adjuvant therapies like chemotherapy and radiotherapy, or less follow-up after treatment. And that's an area that we need to work on next to try and figure out what explains this gap. So in summary, when we did our statistical modelling to try and understand this gap that we see at 5 years, we find that it could partly be explained by differences in age, spread of disease, urban, rural, remote place of residence, differences in socioeconomic status and comorbidities in surgical treatment, but most of it really was due to differences in comorbidities in surgical treatment. So that's really where we're going to focus our efforts on as well as looking at the adjuvant therapies as well. The other side of it is also a qualitative research project, which I showed, which is that big green arrow down the bottom, and that's where we went and asked people really open-ended questions about things like, what do you think cancer is? What do you think could be done to improve the cancer journey for Aboriginal people? And what do you think caused your cancer? And that's a few of the questions. We also had a whole myriad of other questions. And from my point of view, the fact that we've got results very similar to what's been shown in Western Australia sort of gives us, again, more confidence that we're on the right track. But it also means that there are problems there that need to be addressed across the country as well. So some of the things we did find from the qualitative research, we found that the cancer journey could be improved by providing culturally safe and affordable health-related transport and accommodation, upfront financial assistance, a mentor or a buddy or a navigator to help people through their cancer journey, allowing families to be present at doctor's appointments and treatment, having more Aboriginal working cancer centres, and having support groups specifically for Aboriginal people. These are things that could make the journey a lot better. And usually when we give this sort of talk, people nod their heads and say, well, that's obvious, isn't it? You know? But it's good in some ways for us to feel that the research, when we feed it back to people, actually resonates with them in what they see in real life. So it makes us feel that, again, we're on the right track. So where are we up to now? This is sort of my representation of the research process. I talked originally about the grant that we got, then we designed the project, we do our data gathering, we do our analysis, and we communicate it. And then we do a translational piece, and then we go back to the beginning again. And it's really a cycle that we go through. And really where we're up to now is we're up to the communication part, and that's why I'm here today, to try and communicate the results to you, give you a flavour of the sort of things that we're doing. There'll be more and more stuff coming out in the next 6 to 12 months, maybe even longer, hopefully. And so, yeah, look out for it. We're happy to take feedback. If there are things that you want to know that aren't in our research, we're happy to try and work with you to try and get that results out there. But we really want to be not like a lot of other research projects that come, do their stuff and disappear and you never hear from them again. We want to really try and feed back. We've worked really hard on the communication and we want to keep it going. So in terms of communication, there's a few questions we need to ask. One is, who do we communicate to? We know how to communicate to researchers. That's the sort of papers that we write. We have some idea to talk to policymakers like Rosemary, because she's been involved from the start. Health services, we're starting to get a little less confident about that, but we're doing our best there. Clinicians and health workers, well, that's really these sort of people that we hope are in the room today, and that's why we're here today, to try and give you, again, a bit of a flavour of what we're doing, and individuals as well. And if you look along this sort of representation I've got, this is sort of like my idea of what it is. Like in terms of, for researchers, we need to put a very high level of detail and stuff about methods and lots of tables and confidence intervals. Whereas down the bottom here, you guys want to know what it means. You guys want to know what's the impact, what can we do to improve services. You don't care whether I used, a Poisson regression or a linear regression. But the number of conversations we have to have for the individuals is much higher. So we need to balance that out and try to figure out the best ways to get to people and to get our message out there. And I guess that's our next question, is about how do we do it? And as we know, the world is changing. We can do the traditional papers that I've shown, and that's great, and they'll be read by, a certain group of people, and hopefully they'll act on that. But there's other ways we can do it. This is a poster that we put out. They don't call it a poster anymore. They call it an infographic, right? It's a one giant sort of way to dump a whole lot of information onto one piece of paper, and hopefully people will understand what it means. Facebook and Twitter, the average age of an Aboriginal person in New South Wales is 22 years old. So these are the people who will, these are the things that, these are the communication methods that they'll understand and that will get to them. So we're quite active in that, in this Facebook and Twitter space. Traditional reports, like's been shown, that also has an audience as well, perhaps a slightly older audience. And again, we need to look at all those avenues to get there. Talks, like I'm doing now, out here, talking to you. And finally, YouTube, other things like that, things that will be out there and accessible to anybody with a phone or a computer. But what have we learnt really after all this research, after 10 years? This is a snapshot of what we've learnt. We need to know more about treatment, access to treatment, and particularly radiotherapy and chemotherapy. We need to find out ways to make it more accessible and more acceptable to people. We need more research into palliative care and supportive care. That question that we thought we were answering 10 years ago is actually just the tip of the iceberg, as you might imagine. And so really that's the sort of things, and Gail's work and the work from West Australia also will be there as well. In the end, trying to find out what caused that mortality gap, really the causes will be complex, and so the solutions will be too. And so it will involve people from all levels, from the ground workers like you and I to people who are important, like Rosemary and other people like that. So it'll involve, coordination, communication between all those levels of government and planning and service delivery. And so really for us, even though it seemed to be down the end of that diagram, really this is just the first step of our project. Thank you.